More than 70% of adults over 50 show some degree of gum recession. Not mild sensitivity, not occasional bleeding when you floss too hard. Actual, measurable recession. The gum tissue pulling away from the tooth, exposing the root surface beneath, creating pockets where bacteria colonize and bone loss begins. Plaque-induced gingivitis affects the majority of adults in this age group, and when left untreated it progresses to periodontitis, the stage where tooth loss becomes not a possibility, but a probability. And the mechanism behind that progression is not what most people think. It is not that the bacteria themselves are eating away at your gums. It is that chronic inflammation from bacterial biofilm triggers an immune response so aggressive that your own immune system begins breaking down the gum tissue in what researchers describe as immunological friendly fire. Your body attacking itself because it cannot clear the infection any other way. I have sat across from patients in their 60s and 70s who believed gum recession was irreversible aging, something you accept, something you manage with expensive procedures or specialty toothpastes that do not address the underlying bacterial load driving the destruction. And in case after case, when I asked whether anyone had ever discussed oil pulling as an adjunct therapy, the answer was the same. No, not once. Not at the hygienist appointment, not at the periodontal consult, not in the conversation before the deep cleaning or the gum graft. The research on this intervention has been published in peer-reviewed dental journals for years. Randomized controlled trials, meta-analyses, studies with sample sizes large enough, and follow-up periods long enough that the results are not anecdotal. They are statistically significant and clinically meaningful. And yet the conversation almost never happens in the standard 6-minute cleaning appointment. But I won't allow this to happen anymore. That is why I created this channel, to expose the system and to share what is best for you and your health. Hi, I'm Dr. John. Subscribe and hit like. We're building this to 1,000 subscribers on one principle. The system profits from your sickness, not from you being healthier. In this video, I am going to walk you through 2 specific oils that clinical research shows reduce plaque, lower bacterial colony counts in the mouth, and improve gingival inflammation scores within 30 days. The exact names, the exact protocols used in the studies, the numbers so you understand how significant the effect actually is, the realistic timeline so you know what to expect week by week, the mechanism explanation so you understand why these oils work when standard mouthwash often fails long term, and the specific mistakes that will make this fail even if you are doing everything else correctly. One important note before we start: this is not a replacement for brushing, flossing, or seeing your dentist. Every study we will cover used oil pulling as an adjunct therapy, meaning it works alongside standard care, not instead of it. The goal here is not to avoid professional treatment. The goal is to give your gums a fighting chance between cleanings using something that costs less than $5 and sits in most kitchens already. Now, here is what is actually happening in your mouth right now, and why these 2 oils work in ways that surprised even the researchers conducting the trials. Picture the surface of your teeth and gums as a battlefield. Plaque is not food residue. It is a bacterial biofilm, a structured community of microorganisms that adhere to tooth surfaces and gum margins, produce acid that demineralizes enamel, and release toxins that trigger inflammation in the surrounding tissue. Your immune system responds by flooding the area with white blood cells and inflammatory cytokines. In a younger mouth with strong circulation and robust immune reserve, that response clears the bacteria faster than damage accumulates. But after 50, 3 things change simultaneously that tip the balance in favor of the bacteria. Saliva production declines, and saliva is your mouth's primary defense mechanism, washing away food particles and neutralizing acid. Gum tissue loses some of its structural integrity as collagen synthesis slows with age, and immune function becomes less precise. The inflammatory response stays elevated longer, doing collateral damage to healthy tissue, while the bacterial biofilm continues rebuilding between brushings. That rebuilding happens fast. Studies measuring plaque regrowth show that even after a professional cleaning, bacterial colonies begin re-establishing within hours. By 4 days post-cleaning, plaque has returned to clinically significant levels in most adults. Standard brushing and flossing disrupt that biofilm mechanically, but mechanical disruption alone does not address the bacterial load living in the pockets between tooth and gum. the spaces your brush cannot reach, the areas where inflammation is already underway. That is where oil pulling creates a second line of defense that works through an entirely different mechanism, one that researchers did not fully expect to see when the first trials were designed. The oils do not just coat the surface, they penetrate the biofilm, disrupt bacterial cell membranes, reduce the total microbial load in saliva. But this is the part that matters most for seniors dealing with recession and inflammation. They do it without the side effects that make pharmaceutical mouthwashes problematic for long-term use. No burning, no staining, no disruption of the oral microbiome's beneficial bacteria. With that foundation clear, here are the two oils the research consistently identifies as the most effective for gingival health in older adults. The first oil is virgin coconut oil, and I want you to understand exactly what the research shows, because the effect size is not subtle. A 2020 systematic review by Woolley and colleagues analyzed 4 randomized controlled trials involving 182 participants with follow-up periods ranging from 7 to 14 days. Across all 4 studies, coconut oil pulling produced a statistically significant reduction in plaque index score with a p-value less than 0.001, meaning the probability that this result occurred by chance is less than 1 in 1,000. The same review found a statistically significant reduction in salivary bacterial colony count with a p-value of 0.03. One of the included studies also measured tooth staining as a secondary outcome and found that coconut oil produced significantly less staining compared to chlorhexidine mouthwash, the pharmaceutical standard, with a p-value of 0.0002. That matters because chlorhexidine is effective but cannot be used long-term, precisely because of staining and taste alteration. But the study I want you to pay closest attention to is the 2023 prospective clinical trial by Priya and colleagues. 75 patients with plaque-induced gingivitis were enrolled and instructed to perform coconut oil pulling daily for 30 days. Plaque index at baseline measured 1.518 plus or minus 0.084. By day 30, it had dropped to 1.090 plus or minus 0.054. That reduction is highly statistically significant, with a p-value less than 0.001. Gingival index, the measure of inflammation and bleeding, started at 1.178 plus or minus 0.124 and dropped to 1.023 plus or minus 0.020 by day 30, also with a p-value less than 0.001. Here is why those numbers matter in practical terms. A plaque index reduction of that magnitude means visibly cleaner teeth, measurably less bacterial film on tooth surfaces, and a reduction in the substrate that feeds the inflammatory cycle. When plaque index drops from 1.5 to 1.0, that is the difference between teeth that feel fuzzy and coated by mid-afternoon and teeth that still feel clean 8 hours after brushing. A gingival index reduction means less bleeding when you brush, less swelling at the gum margin, and this is what patients notice first: less sensitivity when eating or drinking something cold. The gingival index scale runs from 0 to 3. A score of 1.178 at baseline means mild inflammation, visible redness, and bleeding on probing. A score of 1.023 at 30 days means inflammation is resolving, gum tissue is returning to a healthy pink color, and bleeding has reduced to the point where flossing no longer leaves blood on the string every single time. That is not a cosmetic change. That is a biological change, the difference between tissue actively breaking down and tissue beginning to heal. The mechanism comes down to lauric acid, a medium-chain fatty acid that makes up nearly 50% of coconut oil's composition. Lauric acid disrupts the lipid membranes of gram-positive bacteria, the species most responsible for plaque formation and gingival inflammation. The second oil is extra virgin olive oil, and this one surprised the dental research community because olive oil was not historically studied for oral health the way coconut oil was. The assumption was that if any oil worked, it would be coconut due to its lauric acid content and the existing body of traditional use in Ayurvedic medicine. But when researchers began testing olive oil specifically, the results were extraordinary. Not just comparable to coconut oil, but in some metrics actually superior. But when researchers began testing olive oil specifically, the results were extraordinary. not just comparable to coconut oil, but in some metrics actually superior for reducing gingival inflammation specifically. A 2025 randomized controlled trial by Valasingam and colleagues compared extra virgin olive oil pulling to chlorhexidine mouthwash over 1 month. The olive oil group showed a mean plaque score reduction of 0.46 plus or minus 0.09. Statistically significant with a p-value less than 0.001. The mean gingivitis score reduction was 0.26 plus or minus 0.04. Statistically significant with a p-value less than 0.0003. Olive oil showed results comparable to chlorhexidine for plaque reduction and an additional benefit for gingival inflammation that chlorhexidine did not match. That additional anti-inflammatory effect is what makes olive oil particularly relevant for seniors dealing with chronic low-grade gum inflammation. A 2023 clinical study by Zumbo and colleagues enrolled participants with gingivitis and had them use extra virgin olive oil pulling daily for 30 days. Plaque index was reduced by 48%. Bleeding index, the measure of how much your gums bleed when probed, was reduced by 64%. Those are not marginal improvements. A 64% reduction in bleeding means gums that were inflamed, friable, and prone to damage are now measurably healthier, more resistant to trauma, and less likely to progress to periodontitis. When a hygienist probes your gums at a cleaning, they are measuring two things: pocket depth and bleeding on probing. Bleeding on probing is a direct measure of active inflammation. A 64% reduction means the inflammatory process that was destroying your gum tissue has been substantially interrupted. That is the kind of improvement that changes the trajectory of your oral health over the next 5 to 10 years. It is the difference between stable gums and progressive bone loss that leads to tooth mobility and eventual extraction. But here is the detail that makes olive oil mechanistically different from coconut oil. Olive oil is rich in polyphenols, hydroxytyrosol, oleuropein, and oleocanthal, compounds with documented anti-inflammatory and antioxidant properties. Those polyphenols do not just reduce bacterial load, they modulate the inflammatory response itself, down-regulating the cytokines that drive tissue destruction in chronic gingivitis. Before I go further, I want to address the comparison that matters most to anyone considering this. How does oil pulling stack up against the pharmaceutical mouthwash your dentist might recommend? A 2024 systematic review and meta-analysis by Zhang and colleagues pooled data from 25 trials involving 1,184 participants. The analysis found that oil pulling showed probable benefit for gingival health compared to non-chlorhexidine mouthwashes. Chlorhexidine was superior for plaque reduction. The standardized mean difference was 0.33, with a 95% confidence interval of 0.17 to 0.49. But oil pulling produced clinically meaningful effects with fewer side effects. No burning, no altered taste sensation, no staining, no disruption of the oral microbiome severe enough to cause secondary infections or dysbiosis. That side effect profile is why oil pulling is particularly well suited for long-term use in older adults who need sustained bacterial control but cannot tolerate the cumulative effects of daily chemical rinses. Now, let me walk you through the exact protocol used in the studies so you understand how to replicate the results at home. The studies used 5 to 10 minutes of swishing daily. The most common duration in the randomized controlled trials was 10 minutes. That is longer than most people expect. It feels like a long time when you first start. Your jaw will get tired. You will want to spit it out after 5 minutes. But the mechanism requires that duration because the oil needs time to penetrate the biofilm, coat all tooth surfaces, reach into the gingival pockets, and emulsify with saliva to trap bacteria. The typical volume used was 1 tablespoon, approximately 10 to 15 milliliters. That is enough to coat all surfaces without being so much that you feel like you are going to choke or gag. If 1 tablespoon feels like too much, start with 2 teaspoons and work your way up. The important thing is that you use enough oil to move freely around your mouth and reach all surfaces. You take the oil, swish it gently through your teeth, pull it between the gaps, move it around the gum line, and keep it moving for the full 10 minutes. Do not swallow. The oil is accumulating bacteria, toxins, and cellular debris from the biofilm. At the end of 10 minutes, spit it into the trash, not the sink. Oil can clog drains, and this is repeated in multiple study protocols as a practical note. After spitting, Rinse your mouth with warm water. Some studies had participants rinse with warm salt water, which adds a mild additional antimicrobial effect and helps clear any residual oil film. Then, brush as usual with your regular toothpaste and fluoride if you use it. The brushing step after oil pulling is important because it removes the loosened biofilm and debris that the oil has pulled free but not fully cleared from the tooth surface. Timing matters. Most studies had participants perform oil pulling first thing in the morning on an empty stomach before eating or drinking. That timing maximizes bacterial clearance because overnight, your mouth has been producing less saliva, allowing bacteria to proliferate undisturbed. By the time you wake up, bacterial counts in your saliva are at their highest point of the day. Morning oil pulling disrupts that overnight buildup before it hardens into tartar or triggers the inflammatory cascade that leads to bleeding gums by midday. Some participants in the studies also performed oil pulling at night before bed. There is no clear evidence that twice daily is significantly better than once daily for plaque and gingivitis reduction, but for seniors dealing with moderate to severe recession or active periodontal disease, the twice daily protocol may offer additional benefit. The research does not contradict it, and clinical observation suggests the extra bacterial clearance helps stabilize inflammation faster in patients with more advanced disease. One important practical note about technique: you are not gargling. You are not swishing aggressively like you would with mouthwash. The motion should be gentle and sustained. Think of it as a slow, controlled pull of the oil back and forth through your teeth. Aggressive swishing can actually be counterproductive. It tires your jaw muscles, makes it harder to sustain the full 10 minutes, and does not improve bacterial clearance compared to gentle, sustained motion. The oil needs contact time with surfaces, not force. Gentle is effective. Gentle is sustainable. Gentle is what the study participants did. Here is the timeline you should expect based on the study data. At 7 to 14 days, multiple randomized controlled trials documented significant reductions in plaque index and salivary bacterial count. That is when you will notice your mouth feels cleaner in the morning, your tongue looks less coated, and the filmy sensation on your teeth between brushings starts to disappear. You will also likely notice that your breath is better, not because oil pulling is masking odor, but because it is reducing the bacterial load producing volatile sulfur compounds that cause bad breath. At 30 days, plaque index reductions of up to 48%, gingival index reductions, and bleeding index reductions of up to 64% were documented in the Zumbo 2023, Priya 2023, and Valasingam 2025 studies. That is when you will see measurable changes. Less bleeding when you floss, gums that look pinker and firmer rather than red and swollen, and a reduction in the sensitivity that makes eating cold or acidic foods uncomfortable. Clinical observations in several studies noted that patients reported subjective improvements in sensitivity and bleeding within 5 to 10 days, even before objective clinical measures showed statistically significant change. That early subjective improvement is real and worth paying attention to because it tells you the inflammation is beginning to resolve even before your dentist can measure the change with a probe. Now I need to set realistic expectations because this is where misunderstanding creates disappointment. Oil pulling reduces plaque, reduces bacteria, and reduces inflammation. It does not regenerate lost gum tissue. No study claims full regrowth of receded gums. What oil pulling does is halt or slow the progression of recession by removing the bacterial stimulus driving the inflammatory destruction. If you have moderate recession, 2 to 3 millimeters of root exposure, oil pulling will not make that gum tissue grow back over the root, but it will reduce the inflammation that would otherwise cause that 2 millimeters to become 4, and 4 to become 6, and 6 to become bone loss severe enough that the tooth loosens. That stabilization is not a small thing. It is the difference between keeping your teeth and losing them over the next decade. The research consistently shows oil pulling works best as an adjunct to brushing, flossing, and professional cleanings. It is not a replacement for any of those. It is an additional tool that addresses a bacterial reservoir standard care does not fully reach. Think of it this way. Brushing removes biofilm from the surfaces you can reach with a brush. Flossing removes biofilm from between teeth. Oil pulling reduces bacterial load in the gingival pockets, the spaces between gum and tooth where your brush cannot reach, and where chronic inflammation starts. All three work together. None of them is sufficient alone. That integrated approach is what the research supports, and that is what produces the best long-term outcomes. Let me tell you about a patient. I will call her Margaret, 73 years old, former teacher, meticulous about brushing twice daily and flossing every night. She came to see me because despite doing everything her dentist told her to do, her gums were still bleeding every time she flossed, and her hygienist had told her at her last cleaning that her recession was progressing, and she might need referral to a periodontist for grafting. When I asked whether anyone had discussed oil pulling with her, she looked at me like I had suggested something from a health food store pamphlet. I walked her through the research, the Woolly Systematic Review, the PRIA clinical trial, the Vallisingam ARCT, comparing olive oil to chlorhexidine. I gave her the exact protocol. 1 tablespoon of extra virgin olive oil, 10 minutes every morning, spit into the trash, rinse and brush. 30 days later she came back. Her gums had stopped bleeding. The sensitivity she had been managing with desensitizing toothpaste for 2 years was gone. Her next hygienist appointment 3 months later noted stable gingival margins, no further recession measured. Margaret told me she wished someone had told her about this 10 years earlier. That conversation, the one that never happened until she was 73 and already dealing with a recession significant enough to warrant a graft referral, is the gap this video is closing today. So, here is what to do with all of this. The first step is to choose your oil. Both coconut oil and olive oil are backed by randomized controlled trials showing statistically significant reductions in plaque and gingival inflammation. If you have moderate to severe gum inflammation, gums that bleed easily, look red and swollen, and feel tender when you press on them, extra virgin olive oil may offer a slight advantage due to its polyphenol content and additional anti-inflammatory activity. If your primary concern is bacterial load and plaque control, heavy biofilm, chronic bad breath, gums that feel coated even an hour after brushing, virgin coconut oil has the most extensive research base, and the lauric acid mechanism is well documented for bacterial membrane disruption. You can also alternate between the two. There is no evidence that switching oils reduces efficacy, and some clinical practitioners recommend rotating to benefit from both mechanisms. Coconut oil for bacterial clearance, olive oil for inflammation control. The second step is to commit to the timeline. Oil pulling is not a quick fix. The studies showing meaningful gingival index reduction followed participants for a minimum of 30 days. You will notice subjective improvement, less bleeding, cleaner feeling within the first week to 10 days. But the objective clinical changes, measurable plaque reduction, and measurable inflammation reduction take the full month. If you try this for 5 days and do not see a dramatic change, that does not mean it is not working. It means the mechanism requires sustained daily use to reduce bacterial load enough that inflammation begins to resolve. The bacterial ecosystem in your mouth has been building for years. Disrupting it takes consistent daily intervention over weeks, not days. Stay consistent. Do it every morning. Miss a day, and the bacterial load rebounds slightly. Miss 3 days, and you lose most of the progress you made in the first week. Consistency is what produces results. The third step is to integrate it into your existing routine, not replace anything. Oil pulling works as an adjunct. You still brush twice daily. You still floss. You still see your dentist for cleanings and checkups. What oil pulling does is reduce the bacterial load between those cleanings, so your gums are not spending months in a state of chronic low-grade inflammation waiting for the next professional intervention. That sustained bacterial control is what makes the difference between stable gums and progressive recession. Think of oil pulling as the thing that keeps your baseline lower so that when you do go in for a cleaning, your gums are healthier going into the appointment and recover faster coming out of it. But here is the detail most people miss. Bring this information to your dentist or hygienist at your next appointment, not as a challenge, as a conversation. Say, I have been using oil pulling as an adjunct to my regular routine, and I would like you to evaluate my gingival health and plaque levels compared to my last visit. That objective assessment, a trained professional measuring plaque index, probing depth, and bleeding on probing, is the data that tells you whether this intervention is working for your specific mouth. Some people respond more dramatically than others. Some see plaque reduction within 2 weeks. Others take the full 30 days. The only way to know is to track it clinically, and your dentist has the tools to do that measurement. Ask for the numbers. Ask them to write down your plaque index, your gingival index, and your pocket depths. Compare those numbers to your next visit in 3 months. That objective tracking is what turns this from an anecdotal experiment into a documented clinical intervention. Before I close, I want to ask you directly. How many of you watching this right now have been told by your dentist that your gums are receding, that you have gingivitis, that you might need a deep cleaning, or a referral to a periodontist. But nobody ever mentioned oil pulling as an option to try first. Write yes or no in the comments. Your answer helps the next person watching understand they are not alone in this. But here is the final piece that makes all of this actionable rather than theoretical. Start tomorrow morning. Not next week. Not after your next dental appointment. Tomorrow. 1 tablespoon of oil. 10 minutes. Spit, rinse, brush. Do it for 7 days and notice what changes. Do it for 30 days and measure what changes. Do it for 90 days and ask your dentist to document what changes. The research is there. The protocol is clear. The cost is negligible. The side effects are non-existent. The only variable left is whether you actually do it. And that variable is entirely in your control. If you have been told your gums are receding, if you see blood on your toothbrush every morning, if your dentist has mentioned words like gingivitis or periodontitis or graft, you now have a clinical intervention backed by peer-reviewed research that you can start using tonight without a prescription, without an appointment, and without waiting for someone else to tell you it is okay to try. That autonomy is rare in modern healthcare. Use it. If this channel is giving you the kind of specific research-grounded health information that does not fit inside a standard appointment, subscribe right now and hit the bell.